We have a jam-packed agenda for the day. I know we're all really looking forward to it. So let's get started. Welcome. My name is Stephanie Schell. I'm the Executive Director of the Pennsylvania Public Health Association, and we're all so excited to welcome you today to our very first Mid-Atlantic Partnership Regional Conference. We hope this is the first of an annual event, and we're so grateful to all of you for joining and for being with us today. It's our first time doing a virtual conference, and we want to encourage you to reach out to Brooke Spencer with any questions or technical issues. You can find her on the Whova app or website. So just give her a nudge if you're having any issues or challenges or have any questions. And Brooke's going to talk more with us later about some of the features that we have as part of our virtual conference that you can take advantage of today. And with that, we want to get started. So let me turn it over to my friend and my colleague, Richard Cohen, also my boss, of course, Dr. Richard Cohen, who is the CEO and president of Public Health Management Corporation, and a long-standing public health leader and in our region, in our country. And so, Richard, take it away.
Thanks, Stephanie. I really appreciate it. And long-standing, it means older. And we could say old, but long-standing. So thank you so much. I'm so excited to welcome you. And as many of you know, the Pennsylvania Public Health Association, something near and dear to my heart, is now a part of Public Health Management Corporation. And we're very proud about the work that we do. As Stephanie alluded, I've spent almost 50 years as a proud member of APHA and PPHA. And so this makes this conference even more exciting to me. I'd like to welcome you to the first ever Mid-Atlantic Public Health Conference. And we hope that this will be one of many, many to come. The conference reflects our commitment to addressing public health challenges across the region. We recognize that these issues are impacting our health and our well-being, and they don't stop at state borders. So the issue of a regional conference bringing us all together is so important. They don't stop at state borders. They don't stop at regional levels. They bring us all together. And so this conference is important for all of us. I'm also really, really excited that over the years at APHA, I've talked with our colleagues in the region, particularly folks in Delaware, folks in Maryland, in this case, Tim and Jody, and we've talked about how we bring us all together, how we work better together collaboratively to do things. And this conference is the outgrowth of those discussions and those dreams. And what it really took was Jody and Tim, and then Stephanie and the committee that brought this together to make it really happen. And I can't say enough about the great work that these folks have done to bring together what we think is just a terrific conference. It's going to bring lots of ability for you to meet other people, we hope, network with other people, and work together in really important ways. It will take all of us to emerge from this COVID-19 pandemic with strength and resilience. And with that, this is public health's moment. This is our opportunity to let people know what public health does and why it's so important to all of our communities. I don't know about you, but I've tried to explain to people what public health is for many, many years. And although I did the best I could, they seemed confused. Now people say, now I finally understand what all of you do and why it's so important. And I think it's important that we take this moment to help people better understand the broad aspects of public health as a vaccine rolls out, so that we can make sure that public health has the kind of funding and support that it needs going forward. Same time, we especially need our public health students and young professionals to both follow in our footsteps and lead the way towards a healthier future. So it's really, really important that our students are here and that they work with us. We want to help you in your career as you move forward. And it's great that we have some academics here, and Kathy will be next and can talk a little bit more about that. Over the next day and a half, we'll have the opportunity to learn together across a broad array of public health issues. I hope we all can take what we learn and use it to strengthen our strategies, our connections, and our commitment. And that's the great thing about public health. We do so many different things, and the real issue that we need to do moving forward is to connect those things, because the people, the families, and the communities we serve need the connectedness of public health in serving them. I again want to thank all of you for joining us today. I want to thank our partners, the Academy of Medicine, Delaware Public Health Association, and the Maryland Public Health Association, and in particular, Stephanie and her committee for the incredible work that they've done to make this all happen. And our very generous sponsors, Highmark of Delaware, the AmerisourceBergen Foundation, Christiana and the Mid-Atlantic Training Center, and the University of Pittsburgh. Without their help, this couldn't have happened. So with all of that, I want to welcome you all. I want to just hope you have a great day and a half with us all. And I want to turn it over to Dean Kathy Matt, who is my friend, my colleague, my board member, and a great leader in Delaware and the University of Delaware. So Kathy, welcome and take it away.
Great. Thank you so very much, Richard. And as he said, I'm Kathy Matt, and I'm Dean of the College of Health Sciences at University of Delaware. And it really is my delight and my honor to be part of the group that is welcoming you to this conference, which looks absolutely amazing. I want to speak for a few minutes, if you will, about the importance of education, as Richard mentioned, in training the future healthcare workforce, and what that has been like and is like during the pandemic. No doubt these have been very, very challenging times, but at the same time, it is an amazing time for our students to be learning, and it has created enormous opportunities for us. This year, of course, we have been, I would say, particularly well positioned at UD in health sciences because we just developed a new MPH program. Jen Horney, who we brought in to direct that, has a lot of experience in disaster management and epidemiology. So we're doing an MPH in epidemiology. And we also have Rita Landgraf as a professor of practice, and she is the former Delaware State Cabinet Secretary for Health and Social Services. And so having those individuals as a part of this has really allowed us to integrate them into the training that we have for our students. They've been a tremendous resource to faculty and students, and they've provided guidance and advice. The three of us also taught a course this semester on health, science, and decision-making during a pandemic. You can imagine that there were lots of great debates during this. Although none of us would have wished to be in the position that we are in right now with the pandemic has clearly shone a light also on how integrated physical health and mental health are for the health outcomes of individuals. And it has also shone a light with the recent racial disturbances and showing of health inequities. It's shown how important social determinants of health are on health outcomes. And I think for our students, they are not just reading about these things in a journal article. They are actually living it and experiencing it in the clinics and the communities where they are doing their clinical rotations. So they are seeing close up the health inequities that exist, and they are learning ways and innovating ways to alleviate that. The pandemic has also given us a platform, as Richard had said, to underscore the importance of public health to all health sciences students in all different sectors. And so we really have used that as a platform for our students. I think the other thing is that you also quickly realize that in order to get to good health outcomes, it really takes a team approach. And so we are doing a lot in the areas of interprofessional education, as are our colleagues at other institutions. So physicians and nurses working with physical therapists and speech therapists and mental health experts, and with our public health practitioners, all sort of learning together. How do we provide the best healthcare to individuals that are needed? And then remember also that, of course, with the pandemic, we are recognizing the enormous need for a future generation of healthcare workers that are very, very desperately needed. So our students have been working at our nurse managed primary care center at Star Campus on the UD campus. They have been working in the physical therapy clinic and the speech clinic, as well as being out in the community. We have also put our students up front and center in administering surveillance testing, which we are doing inside of the university with our own in-house testing as a way to keep our students safe. But it also is a way that they can actually model healthy behaviors, not only to our university community, but our surrounding community around us. And now, of course, we are getting our students ready to help with vaccine administration. So again, they are getting lots and lots of opportunity and practice during these very, very challenging times. But I think, again, and I think people have talked about this, sort of this, if there is a silver lining for COVID, I really do think that the students that we are training during this time are unlike any other students that we have trained. They are flexible, they are resilient, they are innovative, they know how to make decisions quickly and work in challenging situations. We have had them learning telehealth. We are exploring, and again, all of the clinics, the institutions that are all at this conference today, we're all exploring new ways to deliver healthcare with telehealth and all of that. And so again, sort of, I think the hope in the future is we are educating right now a next generation of healthcare leaders that is critically needed. And none of this, another piece that I want to emphasize, none of this would have been possible and would be happening right now without all of the partnerships. So it really comes back down to the power of partnerships and all of the individuals within academic communities, working with their surrounding communities, the biomedical communities across the institution, it's public health, it's all of the different health sectors within health professions, all working together. Necessity is the mother of invention, right? And so while it has brought a lot of challenges, I think as we move to the future, we will see we cannot go through this time unchanged. We really need to take what it has taught us and use it for a betterment and really to create an even stronger healthcare system and even better health outcomes for our patients and our families and our communities. So thank you so much for welcoming me as well, and my welcome to all of you for being here today. And thank you for all of the incredible work that you do.
Thank you so much, Dean Matt. And I want to just take a moment and apologize to those who had a little trouble getting into the Zoom room for this session. It is recorded, so if you have a chance, watch it later. And I do think we're resolving the IT issues as we go, so hopefully we've got all of the bugs out of the system. And with that, we'd like to turn it over to Dr. Omar Khan from the Academy of Medicine of Delaware. Dr. Khan.
Hi, good morning, everyone. Stephanie, can you hear me okay?
We can.
Okay, great. Thank you so much. It's really my honor to join this terrific group of folks this morning. My name is Omar Khan, and I'm the president of the Delaware Academy of Medicine and Delaware Public Health Association. It's really been a joy to work as a team with this group from across the region, particularly Pennsylvania, Maryland, and beyond. And as I think Dean, Matt, and Richard put it really well, this is public health's time. This is a perfect time to have this discussion. It is also an extremely challenging time. As you could probably tell, I'm sitting in the lobby of a health system right now, and it really shows that we're bringing together medicine and public health in a very new way, certainly for this country, but new and essential ways. There's my mask. I'm seeing patients this morning in one of my clinic times here. And I just saw this morning folks who've been affected by COVID. My family members have been affected by COVID-19. We all know those who have unfortunately passed away from it. At the same time, we have a vaccine and we have a great deal of hope. But whether or not we succeed in this depends greatly upon how we address the social determinants of health and how attentive we are to the public health side of the equation, not just the medical side. But this is, I want to point out, we are the Academy of Medicine and the Delaware Public Health Association. This is the perfect time to look at partnerships across sectors, across states, and to have this regional discussion. So it is really my pleasure to join you, Richard, Dr. Kathy, Matt, Francine, and Rob and Brooke, Jody, and of course our keynote speaker, Lena Wen today. Thank you so much for allowing me to be part of this. Our team, led by Tim Gibbs and Dr. Kate Smith, have done a stellar job, yeoman's job, a leadership job in helping put this together with you, Stephanie, and your team. So thank you for the partnership. I will be looking forward with great anticipation to the presentations in between patients for the rest of the morning, but I will be certainly here and hope to support the team as much as possible. Thank you again.
Thank you so much, Dr. Khan. And before I turn it over to my friend Francine from Maryland, I want to encourage everyone as you're listening to the keynote this morning to put any questions you have in the Q&A box that you can find at the bottom of your screen so we can address them during the panel conversation after the keynote. Francine?
Have to unmute. Thank you so much, Stephanie. Good morning, everyone. My name is Francine Baker, and I'm the president of the Maryland Public Health Association, which is the oldest state affiliate of the American Public Health Association. And I'm so pleased to welcome you all this morning to the inaugural Mid-Atlantic Public Health Partnerships Conference. MDPHA has been energized and supported by this new partnership with our colleagues in Delaware and Pennsylvania. We've been so pleased to be a part of the public health hangouts that began when the pandemic took hold, and now this conference, which has been many months in the works. In addition to this great partnership, MDPHA continues to champion health equity for Marylanders through advocacy and community collaboration. With over 60 community partners, MDPHA has made advocacy and health promotion a staple of who we are. The strength of the association comes from the dedication and passion of our members. This is evident by the creation of the Public Health Action Alliance, which is an initiative that was birthed out of a member's desire to address the unique needs of our community partners during the pandemic and the activities of our members during each Maryland General Assembly session. In fact, for the 2021 legislative session, we have several members actively working towards advocating for many of the issues which we will discuss during these next 2 days, including supporting policies that address racism as a public health issue and advocating for rights of Marylanders to be legally protected from deliberate environmental practices, policies, and actions that adversely affect individuals and communities. Issues which our keynote speaker has been known to also advocate for. And with that, I have the honor of introducing our keynote speaker, Dr. Lena Wen, via a recorded interview by MDPH's very own Jody Gann, a lifelong resident of Maryland and professor of public health at American University, who has served as Maryland's representative of the Governing Council of the American Public Health Association and will serve as the next president of MDPHA. Jody has been instrumental in solidifying this partnership with the incredible Pennsylvania and Delaware Public Health Associations, as well as recruiting students at American University to help provide technical support to the many panelists you'll soon be hearing from. Jody was beyond excited to score this interview with Dr. Wen, who has become a familiar face and a reliable source of critical information about the pandemic on so many of the reputable and influential news outlets, including CNN's medical analyst. And it was on Tuesday that the country's vaccination strategy broadened, so we are especially grateful that Dr. Wen was able to take time out of what was an extremely busy day for her and the media. Our affiliate is especially proud of Dr. Wen because she launched her illustrious career as health commissioner for the city of Baltimore, where she led the nation's oldest continuously operating health department in the US to fight the opioid epidemic. She also treated violence and racism as public health issues and improved maternal and child health. She has also been the director of patient-centered care research in the Department of Emergency Medicine at George Washington University, president of Planned Parenthood, where she worked to reposition the organization as a mainstream healthcare entity that delivers comprehensive care for women and families, and a consultant with the World Health Organization and China Medical Board. Currently, Dr. Wen is an emergency physician and visiting professor of health policy and management at the George Washington University School of Public Health. Dr. Wen earned her medical degree from Washington University School of Medicine and her master's degree at the University of Oxford, where she was a Rhodes Scholar. She completed her residency training at Brigham and Women's Hospital and Massachusetts General Hospital. Dr. Wen has received recognition as modern healthcare's 50 most influential physician executives and leaders, and also top 25 minority executives in healthcare. The American Public Health Association highest award for local public health work. And in 2019, Dr. Wen was named one of Time Magazine's 100 most influential people. Dr. Wen is a bad woman. Our conference planning committee is very, very excited to kick off our 2 days together with this interview recorded on Tuesday with one of our nation's top experts on pandemic response and planning. I now present to you via recording, Dr. Lena Wen.
Dr. Wen, as a huge admirer of the clear, no-nonsense guidance you provide during your appearances on CNN, and as an eager reader of your column in the Washington Post, thank you so much for being with us today. It's such a privilege to have this time with you and to share this interview with my colleagues in attendance at the conference of the Mid-Atlantic Public Health Partnership. All of us here serve as public health practitioners, researchers, and students from Maryland, Delaware, and Pennsylvania. I represent the Maryland Public Health Association. I want to tell you how much we appreciated and respected your leadership when you served as the Health Commissioner of Baltimore City. The motto of the newly formed Mid-Atlantic Public Health Partnership is working across state lines to improve public health in our region. And the pandemic has certainly exposed the many ways that public health challenges cross state boundaries. And while I mention this notion, since we are all eager to learn more about what those of us working in the public health sphere can do to support vaccination and other COVID-related efforts, I'd like to begin with our first question for your comments. So rather than the current practice of having each state receive huge batches of vaccine and devise its own vaccination plan, I know you advocate for a national vaccination strategy. If you were charged with developing such a strategy, what might this look like?
Well, first of all, Jody, it's a real pleasure and honor to join you today. Thank you for your leadership here in Maryland, and I cannot speak more highly of the importance of public health at this time. I think all of us understand why the work of public health is so important, but maybe not everybody does. And so as a result of our work, which by definition is prevention, right, is preventing something bad from happening, as a result, though, people don't really understand what it is that we do. And as a result, public health becomes the first thing on the chopping block when it comes to budgets. And I think we are now really seeing with COVID what happens when there is this chronic disinvestment in public health that's happened all along. But we all are on the front lines every single day, fighting to educate, to advocate, to provide the information that's needed to save people's lives. And so I just wanted to say thank you to everyone for that important work. So I think we've seen in this pandemic what happens when we do not have a national response, full stop. We've seen what happens when there is piecemeal approach to testing, when there isn't a coordinated message, when actually our elected officials openly contradict the message of public health officials. And we've also seen now what happens when the vaccine rollout is such that the federal government appears to have ceded their responsibility at the time that vaccine doses are given to the states. Now, I'm, as a former practitioner in local public health, strongly believe that public health is local and that local governments, state governments, they need to have the flexibility to set up the types of vaccination programs that are most suitable to the locales that they serve. For example, mobile sites to reach individuals who may not have cars in a particular area, not just drive-throughs if people don't have cars, and other settings to really reach people where they are. The key, though, is that local and state public health have been so underfunded, under-resourced, understaffed for many years. Even prior to the pandemic, people were wearing many different hats. And now you're adding on top of that, that the same individuals who are now working on the public health safety net, who are also setting up testing, contact tracing, public education, now these same people also have to stand up a whole vaccination program. And so I think what should have happened months ago is that state and local health departments should have received the funding that they need. They also need the guidance from the federal government, not so that there's micromanaging in every element of their response, but rather the federal government should be setting targets and then asking each locale, what is it that you need to meet this target? What resources do you need? Is it that you need people? Do you need people to come and staff testing sites while you set up vaccination programs? Do you need federal government's help to set up these mass vaccination sites? Do you just need resources to scale up yourself? Maybe there are regulations that are really cumbersome that can be dealt with on the federal level instead of each locale figuring this out on their own. Maybe it's scheduling systems that are overly complex and each locale is doing Eventbrite or SurveyMonkey to try to schedule appointments. Maybe that's something the federal government can help with. But I think ultimately, on the local level, it is really critical that local leaders are allowed to lead in this process.
We share your frustration with the difficulties that states and local governments are having with distributing the doses they have and the time that it's taking to develop the capacity and logistics for mass vaccination. And now, as we hear, the wasting of vaccine. Can you expand upon your support for maintaining the availability of vaccinated?
Look, I certainly want for the doses of vaccines to be distributed as quickly as possible because we know that every dose that's sitting in a freezer on a shelf somewhere is a dose that if it were given to someone, it could save their life. And so we really should expedite this process. I do have concerns that if we give out all the first doses and for some reason there is a production snag and we're not able to get second doses to people in the way that they were promised, that there are some real ethical concerns. I have patients coming who already have vaccine hesitancy for any number of reasons. And one thing that's really important in reassuring them is that we are not cutting corners in the scientific process in any way. And if we are then not giving people the second dose of the vaccine as they were promised, I think that could lead to a lot of confusion, given that this is how these vaccines were studied. And so I think, again, getting the vaccines out quickly is really important. We need to be expediting the administration of the vaccine, and there needs to be a guarantee of supply before we distribute all the available doses. So again, that we're really being able to follow the science here.
Okay, thank you. So what is your opinion on the hierarchy or the most beneficial order of subgroups of the population to get vaccinated? And do you think this model should be followed across the country? Just minutes ago, we heard that adults over 65 and adults with pre-existing conditions will now be considered a priority group. Can you tell us more about your thoughts?
I would support any efforts to expand eligibility in a way that we could speed up the vaccination process. There are reports all over the country of a mismatch between supply and demand, such that there are doses of the vaccine that are going to waste, which I think is just something that's totally unacceptable. We also know that people on the ground, the nurses and pharmacists, need to be given maximal flexibility because they may encounter situations where more people are vaccine hesitant than they might have assumed, and there could be open vials. Again, these doses are so precious. There are so many people who really want access to them, and so being able to give them maximal flexibility in administering the doses is important. And so the expanded eligibility, I think, makes a lot of sense from that standpoint. Also, it makes sense because our healthcare systems are overwhelmed right now all over the country, and they're overwhelmed because of older individuals who are more likely to be hospitalized and to get severely ill and unfortunately to succumb to the illness. And so if we're able to give it out to older individuals, so much the better.
Great, thank you. With vaccination happening at a slower rate than needed, what kind of services can public health professionals who aren't on the front lines, with our skills in communications, education, tracking, and evaluating, support our local health departments, hospitals, and organizations charged with this Herculean task? We have relationships in the community, such as connections to community centers and other indoor and outdoor locations. That could be used as vaccination sites. We're knowledgeable about appropriate community partners. We'd love to hear your thoughts on how we can be more useful without getting in the way or causing a burden to the organization and the plans.
Yeah, so I think there are two important areas here. One, you mentioned about the importance of education and lending your voice. I think that's so critical. Every single person right now, but in particular, those who are educated in public health principles need to be engaged in advocacy and education. There's so much misinformation and active disinformation that's happening for all kinds of reasons that I think we don't need to get into here, but just to say that there is a lot of misinformation, disinformation out there. And so it's up to all of us to find the venues that we can use our voice. That may be as simple as talking to our friends, our colleagues, our family members who may have other views, and meeting people where they are in these views. Depending on what it is that we are, where it is that we're using our voice. Maybe some of you are writing, maybe some of you are active in social media, maybe some of you are working already with community groups. All those are important venues for getting out accurate information as well. Then I think you raised the other point, Jody. That's an excellent point about getting out and being useful while not getting in the way. I think so often my experience has been that whenever there is an emergency, there are a lot of well-intentioned people who want to assist. But what happens is that they have a very specific intention of how they want to assist. And it's not my job to be the matchmaker. And for somebody who is in a position of authority, who is already trying to oversee all these overwhelming parts that are coming together in a vaccine response and a pandemic response, they don't have time to be your matchmaker either. And so I think what could be the most useful, instead of you coming and saying, I want to do exactly this, I am really skilled at data, and somebody else says, I know this park that can be repurposed. Instead of that, come to the table and say, I will help you with whatever it is that you need. Go to your local health department. You can also go to local nonprofits and businesses that may need help too, or schools that may need assistance, and say, I will do whatever it is that you need. And I think that type of being the Swiss Army knife, for lack of better words, for assistance is going to be appreciated. And I think those needs are also going to evolve over time. Maybe right now there's a need to stand up vaccination sites. Maybe over time there's going to be a data management and tracking need. Maybe over time there's going to be an analysis need. Being the Swiss Army knife to help in all these situations, I think, is the best approach.
Utilizing our communication skills, how can we be consistent with our messages to reassure the public about the vaccine safety and to reduce vaccine hesitancy, especially among people of color who have reasons to proceed cautiously as they remember atrocious events in the past and may feel mistrust about medical treatment and injections?
It's such a great point, and I think this really begins with acknowledging where people are and acknowledging that there are real reasons that people have for vaccine hesitancy. Maybe it is because of historical, and I say historical, but not in the not so distant past, of certain communities being experimented on unethically and illegally. Maybe there is known distrust in the medical system. Maybe also people just really have questions. They might have questions about possible politicizing of the vaccine process, approval process, and it's up to us to assure them about the science behind vaccine safety and to talk about the vaccine process. And so I think it's acknowledge where people are coming from and then to address their specific concerns.
Okay, thank you. And also related to messaging, as public health folks, we understand that even those who've been vaccinated may need to wear masks throughout 2021 until herd immunity is achieved. But how can we easily explain this and encourage the public to remain vigilant about mask wearing?
Really difficult, because pandemic fatigue is very real, and we know that that many people have already done a lot and sacrificed a lot in this pandemic. But I do think that convincing people to hold out for just a little bit longer is going to be really important. And so I think, again, meeting people where they are, recognizing that it's been really challenging, and also proposing, as we do in public health, about harm reduction approaches. We know, for example, that being outside is much better than being inside. And so we're not telling people never to see their loved ones, but rather to do so in a safe manner. Outside, household spaced at least 6 feet apart will also be really important. And I think that type of empathetic messaging that recognizes how difficult things have been for so many will be really important.
Dr. Wen, thank you for your tremendous dedication and for being there for us during what has to be the darkest days of the pandemic. Over the next 2 days, the public health professionals from Maryland, Delaware, and Pennsylvania attending this virtual conference will be discussing and collaborating regarding the recommendations you've given us. So thank you again for your time, especially on this news-breaking day.
Great. Thanks so much, Jody, and thanks to Dr. Wen. And again, while we don't have Dr. Wen live and in person with us, we do have some wonderful regional experts in infectious disease who are here to talk with us and answer some of our questions about the coronavirus vaccine. So please put your questions in the Q&A box that you see at the bottom of your screen. And with that, I'm really pleased to introduce our two panelists who are with us this morning. First off, Dr. Marci Drees, who is the Chief Infection Prevention Officer and Hospital Epidemiologist for ChristianaCare. Dr. Drees graduated from the University of Chicago Pritzker School of Medicine and did her residency in internal medicine at the University of Colorado Health Sciences Center in Denver. She also completed a diploma of tropical medicine and hygiene at the London School of Hygiene and Tropical Medicine in England. Her work in public health and epidemiology began in 2002 when she became an officer in the Epidemic Intelligence Service for the Centers for Disease Control and Prevention. And she then spent 3 years at Tufts Medical Center in Boston, where she completed 2 fellowships. And she joined ChristianaCare in 2007. Her other roles in the health system include providing care for patients living with HIV and/or hepatitis C for the William J. Holloway Community Program, and she serves as the chair of the Infection Prevention Committee. We're so lucky to have her with us today, and as you can tell, she's incredibly busy, and so grateful to have her with us. And she'll be joined by my colleague, Dr. Robert Henninger, who has served as the medical director for the Public Health Management Corporation, PHMC, since 2019. Dr. Henninger's current focus is providing clinical services, including COVID vaccines, to the low-income, underserved, minority, addicted, and homeless populations in the city of Philadelphia. Prior to his transition to the civilian sector, Dr. Heininger served 12 years as a physician and public health officer in the U.S. Army. During his military career, Dr. Heininger served as the Director of Training and Education for the U.S. Army Medical Research Institute for Infectious Diseases. And he also served as Public Health Emergency Officer for Fort Stewart, Georgia. I could go on and on about both of these esteemed leaders, but we're gonna get going with some questions. And as you're listening to them, really encourage you to take the live poll that we have up right now. Let's get started. Dr. Drees, I'm going to start with you if you don't mind, although Dr. Heininger, you're going to get the same question. We'd love to hear a little bit about your initial reactions to what you heard Dr. Wen speak about, and particularly if there's any points she made that you would like to offer a different perspective on. Dr. Drees?
No, I think overall, I mean, it's a balance, you know, in terms of the rollout. I know everyone has been so frustrated that it hasn't gone more quickly, but I think you also need to recognize this is the largest vaccination campaign that we've ever attempted in a very short period of time. And I think, you know, and while it started more slowly, it's ramping up pretty quickly. And I think we're seeing people who initially were a little bit hesitant about vaccine. Now that, you know, we're a few weeks into it, they're changing their minds, and because they're seeing their friends and colleagues getting it without incident. So I think it's definitely ramping up and accelerating. And we're hoping to really move through 1A to 1B to 1C, you know, relatively quickly. And I think, you know, there is that, you know, on the one hand, it's like, well, if the federal government controlled everything, you know, it probably would be more coordinated. But I think, you know, what Dr. Wen said about having that local flexibility is really important too. So there is that dichotomy there that, you know, you want flexibility, but then it looks more disjointed. You know, I don't know that there's a perfect balance there.
Great, thank you, Dr. Drees. Dr. Heininger?
Thank you. Yeah, I will second Dr. Wen's thought that the rollout kind of highlights some of the gaps that we have in public health, specifically, the way that we are funded. That a lot of people don't understand what it is we do until something bad happens, and then we realize, the importance of it. My background, I started my public service in emergency services, so police, fire, and EMS, and I look at public health as an emergency service, but we're certainly not structured the same way as our other community partners. If you take fire, for example, if your local fire department was allowing a certain percentage of your community to burn down every day, then you would probably do something about it. But for public health, we're okay with there being a certain level of disease in our community and not addressing it from a public health perspective. So I second Dr. Wen's notion that this definitely highlights some opportunity for improvement. Legally speaking, at least, epidemic responses are the purview of the states. They are local responses. You could argue whether or not that is a smart move. I think that we've certainly seen some of the gaps that can create, when we see a national rollout like this, but that is how the law is set up. A lot of people see the CDC as some kind of group that's going to come in and, land a helicopter and tell you exactly what to do and handle your problem for you. And that's just not the case. They're a consulting body. They tell you what right is supposed to look like, and you need to do what you need to do locally to get to that. So point taken that Dr. Wen believes that we should have more of a federally coordinated response. At this point, I don't think we're going to, see that. And so it's going to be our responsibility locally to get this thing out.
Great, thank you. Let me take the first question from my colleague Tim, and again, we'll give each of you a chance to address it if you're interested in doing so. We've heard a lot about mutations in the virus and it becoming potentially more virulent. Can you comment on the efficacy of the existing vaccines for new strains? Dr. Drees, would you like to go first?
Sure. So, obviously we're watching that situation very closely. The UK strain appears to have mutations in one part of the spike protein, the receptor binding domain. All of the vaccines, both the Moderna and the Pfizer, as well as the ones that are coming for, are in phase 3 trials right now, really target the entire spike protein. So we think that, they're polyvalent enough that any mutations in that RBD section should not dramatically affect the ability of the vaccine to function. That said, we'll have to follow that very closely. And I know there are some initial studies that are just in pre-publication right now that do show that the vaccine is still available, are still working. And we'll just have to, obviously, whenever there's an intervention, whether it's an antibiotic or a vaccine, that puts selective pressure on the bacteria or the virus to try to get around it. So we'll have to keep an eye on that closely. But as far as what we know right now, it does look like the vaccine will still be.
Dr. Henninger, would you like to add anything to that?
No, I concur with Doctor's thoughts. Generally speaking, for viruses, there's an evolutionary pressure for them to become more infectious but less deadly. If you think that the goal of the virus is to infect as many people as possible, it doesn't want to become more deadly because then it kills its host too quickly and it doesn't have the opportunity to spread. But it does want to become more infectious so it can spread to more people. So that tends to be what we see over time. If you can think of, the other common cold, the other coronaviruses out there that are just endemic in the community, that are just common to us and have been around. When they first came out, they probably caused, some significant disease, but over time they become less deadly. So I think that that's what we'll see with this. But of course, we have to watch it. In terms of the vaccine continuing to be effective, I again agree. I don't think that we would see a major genetic shift that it would allow it to escape the vaccine efficacy.
Great, thank you. Dr. Heininger, while you're talking about sort of new strains and variations of the vaccine, someone's asking for an update on the vaccine by Johnson & Johnson, which will only be, as we understand it, will only be one dose. Dr. Heininger, is there anything you can offer on that vaccine? And then Dr. Drees will turn to you.
Sure. So it's still relatively early for the Johnson & Johnson vaccine. Although the initial results look good. They did a study, I think it was around 800 people, And what they're looking for in that is, one, to make sure that they don't have any side effects and they receive it safely, but two, also whether or not it looks like it's efficacious. And what they found was after, I want to say it was 70 days, they were still seeing antibody in their sample group's blood. So it looks like it was effective and they didn't have any major side effects, but 800 people is a relatively small study. So that then leads them to the next larger study. The Moderna and Pfizer vaccines that we're using now, their large studies had around 35,000 people, just to give you a comparison. And so they need to move to the next phase. That'll be a bigger study, and then they have to watch those folks for a period of time. So I don't think that one's going to be on the market within the next few weeks, but if things continue to go well, then probably next few months.
Great, thank you. Dr. Drees, did you want to add anything to that?
Yeah, no, I mean, just that all of the vaccines that are being looked at, part of their initial phase 1, phase 2 study was to look at 1 dose versus 2 doses and different doses. And for the Pfizer, Moderna, and AstraZeneca, they both saw that getting that second dose increased the antibody levels. And that's why they went with a 2-dose series. And for any new disease, if you look at all the vaccine schedules that we have in kids, like almost all of them are multiple doses, and that's pretty normal for the immune system to need multiple doses to get full not only full antibody levels, but the duration of antibody. So the J&J one, they did not see an additional significant bump with the second dose, which is why they felt safe going with a 1-dose regimen. But until you get to that phase 3 trial and see how well it actually works to protect against disease, we don't really know.
Great, thank you. So next question is going to take us in a slightly different direction. And again, would love to hear both your thoughts on this. Dr. Drees, maybe we'll start with you. The question is in regards to vaccination. It comes from someone who doesn't believe in vaccines and is asking about, if you have thoughts on whether or not their intention not to receive the vaccine might affect their ability to work in public health organizations going forward.
Well, I mean, we know that vaccines are among the greatest public health triumphs of the last century, right? So, I think, and unfortunately, I think they're a little bit of a victim of their own success. The fact that we don't see kids dying from polio and becoming paralyzed from polio every fall, like we used to in the 40s and 50s and earlier. We don't see kids with measles. And even for flu, on an individual level, even though we have many flu deaths every year, most individuals don't know someone who's died from flu. And so, the risk benefit of the vaccine versus the illness, I think, is a little bit skewed. As far as, having any sort of requirement, as long as these vaccines are authorized under an EUA, they actually cannot be mandated as a condition of employment. And even if they, once they're fully licensed, which we expect can happen with 6 months of follow-up, then in theory they could be. I think with something so new, even if we were allowed to mandate it, I don't think I would recommend that, just because, we have decades of experience with MMR and flu vaccine, and that's a whole different ballgame than a vaccine that we only have months of experience with. So, I would prefer to use the carrot, not the stick. And really, because I think when people hear, mandate or required, they turn off and they don't hear anything else that you have to say about it. So, I mean, like I said earlier, we had a lot of demand early on, but we also had a lot of people who, just didn't want to be first. And they're starting to come around as they're seeing, their friends get vaccine and do well with it. So, and I think as we start to see fewer healthcare worker infections, hopefully even more people will come along and choose to get the vaccine. But we're really trying to push it in a very positive way and making sure that the questions that people have are answered in an appropriate way, and that's with the right reading level, the right language. There's a lot of misinformation out there about the COVID vaccines that is being spread, so we're trying to combat those myths as well.
Thank you, Dr. Drees. Dr. Henninger, do you want to add anything to that?
I would just say I wouldn't recommend working in public health if you're not vaccinated. I get that, getting a vaccine is a personal choice, and it's a complex choice for most people. And if that's what you choose, that's fine, but it's a personal choice that has the ability, has the opportunity to impact others around you. And so if you want to make that choice, that's fine. But I would also recommend that you then also make choices to reduce the impact you have on others. And so if you're not vaccinated, you may represent a threat to the patients that you're dealing with on a day-to-day basis. And so you may want to think about working in a different environment where you can reduce that impact.
Thank you. And let's sort of stick with the same thread for a second and address another question that's been posed, which is how are our organizations preparing to acknowledge trauma like systemic racism that is carried through generations and answer questions that may be causing hesitancy to receive the vaccine? This person's interested in understanding if we're having explicit conversations on approaches to build trust with communities. Dr. Henninger, can you take a stab at that one? And then again, we'll turn to you, Dr. Drees.
Sure. So, I mean, what we're talking about is trust here, right? And so I get that trust between certain communities and public health at large has been lost due to, some historic events. And we need to work to regain that trust. But when we're talking about trust, it takes a long time to do that. It takes a long time to build trust. And so when we were discussing earlier that public health responses are local, this is part of the reason they have to be local, is you need your local community who you already trust to be part of this conversation. So I can't go into a minority neighborhood and say, you need to get this vaccine right now and expect a positive response. What I do need to do, though, is engage with local church leaders, local community leaders, local clinics, local providers, so that I'm seen as not somebody coming in and dictating, but somebody that's coming in willing to assist with whatever resources I have while they make their own decisions and they make their own choices. So you need to engage with people in the community that already have that trust and hope to, use some of that in order to accomplish the goal that, will benefit everybody else.
Great, thank you. Dr. Drees, do you want to add anything?
Yeah, my computer froze while Dr. Henninger was talking, so I apologize if I repeat anything that he already said. But I think I'm agreeing that finding local champions, and even with the healthcare workforce, like we're watching very carefully, the race ethnicity breakdown of our healthcare workers who are agreeing to be vaccinated versus our overall force, and we're finding that African Americans are underrepresented in those who have been vaccinated so far. So we have a task force that includes our diversity and inclusion experts, our language services, and it's really our ethicists. It's a multidisciplinary group to really focus on that. And I think it's a balance. You don't want to, give the impression that you're targeting that group, because we don't want them to feel like they're guinea pigs for this vaccine, but we want to make sure that you're reaching them on an individual basis and answering their questions. And I think when we've been able to have one-on-one conversations with people, for the most part, we've been able to, dispel any myths, and many of them are then agreeing to be vaccinated. But doing that when you have thousands of people, obviously is not feasible. So we're looking for, local influencers, local champions from within each of those communities to really, have town halls or other venues where people can just interact and get their questions answered.
Thank you. And Dr. Drees, why don't you take you could start with this next question, and again, we'll go back to Rob. And I know you all have talked about part of this question, but there's parts of it that have not been addressed yet. So I'm going to read the whole question, and feel free to just answer the parts you haven't addressed yet. 1 year after COVID-19 appeared, we are now seeing new strains surfacing. How confident are we with the vaccine against these new variants? And what does this tell us about the likelihood that COVID-19 may be similar to influenza in that it mutates often? Is it likely we will need yearly boosters for the COVID vaccine?
Yeah, I mean, I think we've answered some of that question. We don't know yet how long our vaccine will last. It does not mutate as quickly as flu. And so it is a more, that spike protein is relatively stable compared to flu, and we don't see the drift and shift like flu does on a regular basis. But I think, obviously it will depend on how many mutations there are, and if you see that kind of escape variant that gets around the vaccine, as whether there'll be a booster with a new strain. And again, all the people that are in those large phase 3 trials are being followed for up to 2 years just to see how long their immunity lasts. I think they're confident, at least with the mRNA vaccines, that immunity will last some time, potentially more than a year, but until we can actually follow people that long, we don't know for sure.
Great. Do you want to add anything, Dr. Henninger?
No, I agree. I think that, it's always possible. Though you could need another booster that it could mutate, but I think it's less likely. I think coronavirus 19 will act like the other coronaviridae and not act like influenza. Influenza is kind of its own animal in terms of how much it changes from year to year.
Great, thanks. And we'll start with you, Dr. Henninger, with this next question, which is, we've seen approaches to speeding the vaccination rollout by expanding who is eligible to receive the vaccine. Also been concerns about this causing additional chaos with meeting demand in some states. Do you think there should be additional federal guidance and support in order to make this process more effective, or should all of the decisions be left to the states? Dr. Henninger?
I think it's always the goal of the CDC to provide guidance, and we do our best to adhere to that. When it comes to the vaccine rollout, we have competing demands. So one is, ethically and logistically, to an extent, it makes sense to make sure that we vaccinate all of our healthcare workers first, and all the sickest folks first in the nursing homes, and then move to other populations that may be slightly less at risk or less apt to spread the disease. Then another issue is, who has, access at any given time and what their access points are. So, what we were talking about with reaching minority and underserved communities, you've got to meet those folks where you are. So we've had a lot of drive-through COVID testing sites when this all started last spring, and they were drive-through. Well, for, under, poverty-stricken communities, they don't have cars, and so they can't drive through a testing site. So you need to give them another opportunity for a testing site. So we're also have a competing agenda when it comes to how we distribute the vaccine to different groups that can receive it in different ways. And then the last bit is there's just a logistical issue with, once you open the vial, you need to use everything in there. Every shot is precious. So, if I can vaccinate 9 nurses that are working in an ICU and I've got, a 10th dose left, should I vaccinate the janitor? Absolutely, or the secretary or whoever is there, because it's paramount that you use every dose in that vial. So I think, yes, the CDC can provide guidance, but we're all going to have to make good clinical decisions individually, given the resources that we have and the challenges that we're facing. There's no way that the CDC or anybody else, even at the state level, that is going to be able to anticipate every barrier that we're going to encounter. And so on some level, we're just going to have to make our best decision as we move forward.
Thank you. Dr. Drees, do you want to add anything to that?
No, I mean, I think I don't have a lot to add to that, other than, billions of dollars have been devoted to vaccine development, and not nearly as much money has been devoted to vaccine program implementation. So it kind of just goes back to what we were talking about before with, the states need guidance, but they also need funding to actually make this happen. It's an infinitely more complex enterprise than testing, because, not only for the reasons that Rob mentioned, but the fact you have to monitor people afterwards, you have to have the ability to respond to allergic reactions, such like that. And it's way more complicated than a flu vaccine program that we often do out in the community. So it takes time to set all these programs up in the locations that they need to happen. So, and all that needs funding.
Great, thank you. And let's stick with you for a sec, Dr. Drees. The next question is, while the twindemic thankfully hasn't happened, what is the regular flu season looking like this season so far? And is there any evidence that masking and social distancing has impacted the spread of less severe colds?
So yes, I think so. I mean, we've had a handful of cases of flu statewide in Delaware, and typically by this time of the year, we'd have more than 1,000. So it has absolutely impacted flu. And I think that just goes to, yes, masking and social distancing such that people are doing it is not enough to halt the spread of COVID. It has been enough to really shut down flu. And obviously flu is less contagious than COVID. And I think, I don't have young children, I have an elementary school child, but, I've even heard, young kids who typically are, have nonstop upper respiratory infections all winter long are really not reporting that this year. So, so yes, and I'm even thinking like, should this be something that we do every flu season? Because clearly it's way more effective for flu than it is for COVID. And certainly if we weren't doing it, COVID would be so much worse. But yeah, I mean, I think, you know, there definitely is evidence that that's been shut down. And of course, we really pushed flu vaccination early on, you know, before we even had COVID vaccines available, just to try to get everybody done with vaccine as well.
Great, thanks. Dr. Henninger, you want to add anything to that?
No, I mean, I concur. If the flu season this year has taught us anything, it's that masks and hand washing and social distancing work really well at reducing disease burden. You know, if we rely on, there's a number of lines of defense against any infectious disease, and your immune system is the last line in those defenses. And so if you're relying solely on an immunization to protect you from an infectious disease, you're relying on just the last line of defense. And, you know, what we see is all of those other lines of defense are a lot more effective. And so, yeah, maybe we should consider doing some of this moving forward. At least a lot more hand washing would be great. So.
Great, thanks. And again, Dr. Henninger, we'll start with you with this next question. How have public health departments managed to address the pandemic while also balancing other services that cannot go by the wayside? What has that been like?
Yeah, this is really tough for us. This is probably one of the biggest barriers to the vaccine rollout that I think isn't really getting talked about, which is our healthcare system nationally is not built to flex. It is built to meet the daily need, as any other, you know, quasi for-profit industry is. You know, you don't want a lot of waste. And so it's built to be efficient. It is not built to be comprehensive and have the ability to flex where need is. And so in our clinics, you know, we're, you know, treating patients every day for their regular needs. And then on top of it, we do have people that are sick from COVID that we need to see. And we're busy from morning to night. Our schedules are full. And so if on top of that, you say, we need you to go ahead and, you know, vaccinate all of your population and the general public, that's a large burden of work that we need to take on. And even if you give me a ton of funding to do that and say, here, let's throw money at the problem, it doesn't solve the issue for me that I still need to see our regular patients, that I still need to meet their basic needs. And if it's a choice between treating my regular patients and vaccinating somebody in the general public, that creates a little bit of an ethical dilemma because my priority is to my patients. And so I think that's why we see some difficulty in being able to flex and turn on a dime and you know, rapidly be able to begin to vaccinate. So the rate limiting step is not necessarily money, it's usually time and staff. And so these are major issues to cross off, and everybody is running into the same limited resources at the same time. So you can't just turn and hire new staff, you know, to solve the problem because everybody else is trying to hire new staff. So there's some major logistical issues here. If there was a coordinated federal response, you know, maybe it would look something like providing staffing. You know, I would rather see the National Guard helping us give out vaccines than standing guard at the Capitol. And I mean, that's my personal view, but yeah, I think that there's some opportunity there to close some of those gaps.
Great, thank you. And I just want to, before I turn it over to back to you, Dr. Drees, put a plug in for our opening session tomorrow morning, where we will have the leaders of our public health systems from both Pennsylvania and Delaware addressing your questions and speaking with you. So if you are particularly interested in that question, come back tomorrow morning and join us. And with that, Dr. Drees, is there anything you want to add to that, to what Rob just said?
Yeah, I mean, I can't speak for the public health system because that's not where I work, but from a healthcare providing system, I mean, we shut everything down back in March. Like we shut down all but the most emergent surgeries. A lot of our outpatient practices either shut down completely or switched to telemedicine, which accelerated the telemedicine options. You know, 2 years worth of work probably happened in about a month to make that happen. And you know, and what we learned though is that, you know, because of that, as well as because of patients' own reluctance to come in to seek care, there were a lot of negative health effects unrelated to COVID. And so, as you know, as rates went down over in the spring and early summer, you know, we opened things back up, and as rates have worsened again of COVID, we've really tried not to shut things back down to that same extent. You know, We have had to shift away from some of the inpatient surgeries just to make room in the hospital, but kept our outpatient surgeries going as much as possible. And again, I think, the clinics are seeing people in person as well as doing telemedicine when that's appropriate. So, and shutting everything down did allow us to redeploy a lot of those staff who now didn't have a job to do other things like the door screening and all the other COVID related stuff. And one of the challenge has been is as we've reopened, though they're going back to their usual job, and we still have these other new functions that have to happen. So that's been a bit of a challenge. And now, of course, as we're vaccinating in the setting of a huge number of COVID positive inpatients, we've had to really rely on a lot of the nurses who normally would be our vaccine volunteers. They really need to take care of patients upstairs. So trying to rely on, folks that don't have a patient assignment typically, like our nurse educators, our outpatient nurses, our pharmacists, really having to think very carefully about how to get staff to help support these different efforts.
Great, thank you. And Dr. Drees, I think this next question is probably right up your alley. How can public health push for new disease emergence prevention globally to prevent something like this pandemic from happening globally again?
I think, I think like Dr. Wen said earlier, is this has been a chronic underfunding problem. These people don't understand what public health really does until there's a crisis. And, I think we all learned a lesson during Ebola, even before that H1N1. But then, as the crisis subsides, things kind of go back to the way they were because, there's always seems to be something more important in funding than public health. I'm hoping that doesn't happen again, although, I know the human nature probably means it will happen again after COVID is in our rearview mirror. But, obviously we need the surveillance systems out there, both from a laboratory standpoint, as well as, screening for symptoms, making sure that people aren't coming into healthcare systems sick, like staff. Presenteeism is a huge problem that we've been able to avoid in many cases with COVID because now we're screening every health worker as they walk in the door, but that's been a huge problem in the past. And certainly, making sure that everybody with any sort of respiratory symptom is masked, should be something that we really focus on moving forward. But yeah, without those kind of global surveillance systems, we will set ourselves up for this again.
Great, thank you. Dr. Henninger, do you want to add anything to that?
Yeah, for some reason, as a country, we prioritize physical security over biological security. So we spend trillions of dollars on the Department of Defense, and most of that is protection against bullets and missiles and things like that. And I don't know why we don't prioritize our biological security more, because you can see this is, so we had a physical attack on 9/11. And we saw the impact of that, and this is not an intentional biological attack, but you see the fallout of a biological event like this is so much more impactful that I wish we would prioritize our biological security more than our physical security. And I say that as an Army vet. I was paid by the DoD. I was part of that funding, but I wish that we could take some of that money and put it more towards our surveillance system when it comes around these things.
Thank you. And Dr. Henninger, let's have you start with this next question. The question is, long haulers are a sad and unexpected subset of patients who have COVID-19. Are there any new treatments on the near horizon to reduce their burden of illness? I'm going to also suggest you define what we mean when we say long haulers.
Sure. So there seems to be a kind of a strange collection of long-term symptoms, long-term sequelae associated with having been infected with COVID. So these can be chronic coughs that go on for months. It can be even things like depression and other psychosocial issues. So they don't really have the research is very young on what causes that and how to go about addressing it. Most of the treatments right now are just symptomatic. You do the best to help them with their symptoms. We'll probably learn more about it as we go. These people are no longer infected with the virus or infectious, but they continue to have symptoms. So Right now, it probably looks like this is some sort of inappropriate immune response. And so, what we may find down the road is you treat it as you would other inappropriate immune responses, things like, allergies and other, inflammatory disease processes. But it's all still very new. So I don't think anybody's figured that one out just yet.
Great, thank you. Dr. Drees, do you want to add anything to that?
Yeah, no, I agree completely, and I don't have any additional information about that. But that's one thing that we talk about, particularly among our younger, healthier population, when they're considering whether or not to get vaccinated, because they know their risk of severe illness or dying is extremely low. But we do know that they do have a significant risk of having these more chronic symptoms. So it's just one more reason to protect yourself, even if you otherwise are a high-risk person.
Great. Let's turn our attention to young people for a moment. And Dr. Drees, let's start with you with this question. Can you talk a little bit about what your expectations are related to vaccination for children? And then Dr. Henninger will give you a chance to address that. And if either one of you happen to have a crystal ball, can you talk about what your anticipation is related to when we can expect kids to really be back in school in person full time?
Yeah, no crystal ball here. I know, sorry. I mean, certainly trials are ongoing, and this is typical for any new drug or vaccine that you start with adults, then you move your age range further down. And so I think there are trials as young as 12 and 6 of this vaccine. Obviously, kids have a very low likelihood of severe illness, although it does happen, and they have a high rate of transmission. So having a vaccine that not only prevents severe illness, but prevents them from transmitting to others is going to be really critical in these trials. So, I know that they're working on it as quickly as they can, but I don't have an idea of how soon that's going to be available. But I think certainly, having teachers in the next round, and not only just teachers, but anyone working in school or education, janitors on up, having all of those adults vaccinated will help keep the spread. Will help open the schools and minimize the spread as well.
Great, thank you. Dr. Henninger, do you want to add anything to that?
I have a crystal ball, but I use it for lottery numbers. No. So yeah, I agree. There's a lot of talk about herd immunity, and when are we going to get to herd immunity? Because that's kind of what I think people see as the end point with this. And the vaccine is not necessarily the end all be all when it comes to that. So the level of vaccination, immune protection that you need in the general population in order to have herd immunity depends on how infectious the disease is. So if you have a highly infectious disease like measles, you need a vaccination rate upwards of like 90% of the population in order to protect against it because it's so infectious. Something that is less infectious like influenza, you might be able to get away with, a 70, 80% vaccination rate in order to have herd immunity, depending on how infectious flu is that year. We don't know what level of vaccine we need for COVID. We do know that it's a pretty infectious disease though, so it's probably a pretty high level of a vaccination rate that you need in order to get herd immunity. And so right now among healthcare workers, what we're seeing is 60% of healthcare workers, not just the general public, are interested in getting the vaccine. So that's well below the vaccination rate that we would need to get herd immunity. And so if we're really talking about getting completely back to normal, I think herd immunity is something that is still pretty far on the horizon. The other thing that gets us back to normal is that the disease burden in the population is low. So you don't have a lot of people you don't have enough people to make it so that we have herd immunity, but there's just not a lot of disease around, so it's relatively safe to go about your business. I think that second scenario may come along before herd immunity comes along. And so, when does that happen? It happens, it depends on, how quickly we get immunized, how many positive cases we have over the next year. There's a lot of factors that go into it. I'm hoping, and don't count me on this, but I'm hoping things start to look more normal over the summer as we start to get back to being outside, and that reduces the amount of infection in the community. If you're a parent at home and your kids are currently, at home doing school at home, I would plan on, them probably not going back to school this year, not until the fall at the earliest.
Okay, so now that you've crushed the dreams of every school-age parent out there, let's sort of build on that a little bit and address the next question. Again, Rob, we'll start with you. Is there any targeted messaging regarding vaccine hesitancy for specific age groups or any plan that you're aware of? For example, is there a strategic outreach plan to encourage younger adults, particularly those in the age range of 18 to 35, to get the vaccine once it's available?
So the name of the game when it comes to vaccine hesitancy is to listen first and talk later. And so when you talk about, marketing plans and how are we going to convince people to get this vaccine, you're kind of starting off from the wrong perspective, because the first thing you have to do is you have to listen. And so how do you do that, when it comes to large populations? You have to do polls, you have to do sensing sessions, you have to, figure out how to get that interaction one-on-one where you're hearing what their barriers are. Because, vaccine hesitancy, it is not homogeneous across populations. You can't take a minority population and say everybody there has the same reason for being hesitant. You really have to hear their individual concerns. And the biggest thing is this is a personal choice, and you don't ever want anyone to feel like their personal choice is being taken away in this process, or else you're going to lose the argument right off the bat. And so is there a campaign? I would say that education helps. Education is never going to be a bad thing, because it helps people to make that choice on their own. But you've always got to take the tact of this is their personal decision, and you need to understand what their belief system is and what their perceived barriers are before you even try to make advice.
Great. Dr. Drees, do you want to add anything to that?
Yeah, no, I agree with that completely. I think you have to hear where, you have to meet them where they're at and hear what their concerns are. I think we're so far away in the general population of getting vaccine out to young, healthy people that, we're not quite there yet in terms of having an education campaign. But I think that risk of being a long hauler is certainly one of the things that needs to be included. But, within the healthcare workforce, one of the things we started to hear very early on from our young female healthcare workers in particular was this fear of the vaccines causing infertility. And we're like, where did that come from? And, with a few internet searches, you find these myths pretty quickly. And it's based on, very minimal scientific fact. And so we've had to, create, targeted messages, both in our FAQs that are on paper, as well as filming some videos that directly address that particular myth that we were hearing a lot of. And so I think it's, hearing what they are, what the concerns are, and trying to address them with facts.
Great. We're gonna have to wind down in a couple minutes. So we're gonna end with just a couple more questions that I'll ask both of you to address. The first one is, what each of you, like both personally and professionally, can you talk about what subpopulations you're most concerned about right now related to coronavirus? Dr. Drees, maybe you can start.
I think, obviously I'm in the healthcare workforce mode right now. We're still in 1A. We have a large team of people who's going to be focusing on patients, and I have concerns there as well. But I think, the hesitancy among nurses is really concerning. And a lot of that is that what I just spoke about, that unfounded fear of infertility. But there are other concerns as well. But, these are really our frontline people. And, we're seeing a lot of caregiver infections, not because of their patient care, but from the community, from each other. And, the sooner we can get people protected, the sooner, we can keep people from getting sick. And so it's just it's frustrating to hear that when, these people, again, like, if you're vaccine hesitant, you really probably shouldn't be working in healthcare. And I think most of these people are not overall vaccine hesitant, but, just have concerns about this particular vaccine just new. So I'm hoping that, they'll start to come along. And certainly I have a lot of concern about our racial and ethnic minorities and making sure that we're getting the right message to them, and that we're, again, meeting them where they're at, and helping them, understand why we think it's so important that they be vaccinated.
Great, thank you. Dr. Henninger?
Yeah, so we've got actually a number of epidemics going on right now in the city of Philadelphia and nationally. One is there's the opioid epidemic. So we have a lot of addicted persons out there. And then there's also a homelessness epidemic, an unstable housing epidemic in the city of Philadelphia. And those people are, and obviously there's the COVID pandemic. And so those people are kind of being hit from multiple sides, and it makes their prognosis very poor. And so those are the populations that I really worry about. When you talk about somebody who is addicted and homeless and in the middle of a pandemic, and you say, you need to sequester at home, you need to stay in place. They don't have the ability to do that, and they're not going to. And so it is not an isolated issue. It's something that can and will affect all of us if we don't get after these underserved populations, these needy populations. There's also been a lot of funding for COVID activities, which is great. We appreciate it. But some of that funding comes from other public health funding resources, which means that we're taking away funding from, things to help the addicted population and things to help the homeless and unstable housing population. And so then those issues are going to get even worse because we're robbing Peter to pay Paul. So yeah, I definitely worry about those groups and how things are going to play out for them. That the economy is going to suffer too because of this, which makes that even harder. As you try to get somebody who's got a history of addiction or homelessness, and you're trying to get them financially stable and moving forward in their lives, it's a very bad perfect storm for them.
Thank you. And let's end on a positive note. This will be the last question. We've just kicked off a new year, and what a start to the year. I don't think anyone expected any of what has unfolded over the past couple of weeks, but it is a new year, and I'd love to hear from each of you what you're looking forward to professionally, related to COVID-19, related to public health. What are you most excited about in 2021? Dr. Drees?
I mean, I'm really excited about the new administration. I think, one of the tragedies of this is how the CDC, whose job it is to respond to epidemics and pandemics, has been so sidelined and discounted, and its credibility has been really questioned. So I'm looking forward to the CDC having, again, a more public voice, and the administration not sending mixed messages about everything. Masking should never have become a political question at all, and yet somehow it has been. So I'm looking forward to having a much more consistent message from the very highest levels of government on down.
Great. Dr. Henninger?
Yeah, I'll say it's not just for 2021. This has highlighted the importance for public health, I think, in the general population, and I hope that really drums up a lot of professional interest, as people see how important this part of our community is. I see that in the chat box, there's kind of a sidebar conversation going on about how we're talking about we need to hit minority populations, and yet there's no minority representation on our little panel here today. And I totally understand the unfortunate irony of that. We absolutely need more minority representation in healthcare and public health, and I truly welcome it. We don't want to, we want these solutions to come up organically from these communities. I don't ever want to go in and dictate anything. The best I can do is offer resources. So we welcome the help. I really hope that all of this, has shined a positive light on the good work that we do, and that people decide to make it a career choice.
Great. Thank you both so much for giving so much of your expertise and your time this morning. And thanks to everybody who's listening and